This week on the BackTable podcast.
Generally speaking, if it's GE junction and not signet ring cell, we tend to not lap stage patients. Anything that's true gastric, which is farther down into the abdominal cavity below the distal thorax, we do lap stage. I believe my colleague Deepa McGee here, I think she leads our intraperitoneal malignancies group as part of one of my surgical colleagues, quotes me 15% occult, something like that. I base it on anatomy, whether or not to lap stage, and I guess histology as well.
Welcome to BackTable. My name is Eric Lander. I am a member of the Sarah Cannon Research Institute GI Executive Committee and a practicing hematologist and oncologist at Minnesota Oncology, an independent physician-owned private practice in the Twin Cities.
Eric, great to see you in Music City again. Welcome back. Yeah, my name is Michael Gibson. I am a GI medical oncologist. I'm professor of medicine at Vanderbilt University, and I practice at the Vanderbilt Ingram Cancer Center.
Very awesome. Yeah, so we've been tasked with a very fun topic today.
Some would say. I mean, if you love to geek out like we do and think about ways we can make the world a better place, look no further. Maybe that's why we get along. A couple of geeks on a podcast.
Exactly. So today we're going to be discussing resectable gastric and GEJ cancer. We're going to really be focusing on the adenocarcinoma histologies. So we're not going to go further up the tube into the cervical and thoracic esophagus. We're going to stay lower down, relatively speaking.
Understood.
We really just want to make this a discussion of like the current landscape, where we're at today, and also just thinking about how to translate our modern clinical trials such as Matterhorn into clinical practice. So try to keep it applicable here. And I have an expert who has treated, I don't even know how many patients with gastric cancer in the last, I'm not going to date you.
Well, you can.
5 years, 2 years?
I think I finished my fellowship in 2003, so you can do the math.
I was a little under.
It's more than a little and less than a whole lot.
Okay, nice. So, we're going to start way back in time to what were you doing in 2003 for gastric cancer? We weren't, immunotherapy wasn't around, that's for sure.
True.
We were not in a place where we were doing much even chemotherapy for our patients to cure them.
I agree. It was a wind back in time where we did not have even Herceptin. Toga trial, I think and that's for recurrent metastatic disease, was 2013 or something. So this would be in the early aughts, I think you say.
Yeah. I think the classic trial in Asia was early 2010.
Yeah.
So 10 years before that, definitely not giving a ton of chemotherapy for our patients with resectable disease.
True.
It was probably just surgery and hope for the best.
Pretty much, yeah. In fact, I remember reading the paper probably when I was a first-year fellow that talked about adjuvant chemoradiotherapy. It's an intergroup trial, I think, for resected gastric and GE junction. I do not believe we did that for esophagus because we tended to give preoperative chemo RT even back then. But I remember one of my fellows helping me. Speaking of, thank you very much.
That's what we're here for.
The past.
We're really good at writing notes.
He made me a time chart.
Yeah, see, there you go.
Yeah. So
that's better than I ever did.
But we're not going to say. We'll talk later. But the chart was how you integrate the radiation and the chemoradiation portions of this. I think it might have been even 6 months of adjuvant therapy. So it was like a month of 5FU, then 5 weeks of concurrent, and then another couple of months of, I think it was just 5FU. And tell you what, that was not easy. I remember a patient, and this makes you think about sort of how we're doing quality and quantity math. Well, it's not math, but in our heads. And only in retrospect did I realize that I continued to see this patient for several years with just the most chronic GI cramping and malabsorption and dumping, and it was miserable. But as he used to say to me, well, I'm here telling you this.
Yeah.
But I learned to not be a fan of postoperative chemo RT for resected gastric cancer. But fortunately,
makes sense.
The field developed.
Yeah. And so, fast forwarding some, we were kind of doing a hybrid of chemoradiation for some of the GEJ tumors for a while based on cross, and then came the MAGIC trial. What was that like, seeing that come around?
Yeah, it goes back, so you know how old I am, but I can go farther back than the MAGIC trial.
Nice.
Yeah. May I?
Please.
Okay, thanks. I know I'm a little shiny object here, but we will also move back and forth between esophagus and stomach and GE junction, because as you'll see, the trials mix and match those geographic sites on the tube. But for esophageal cancer, exactly. For esophageal cancer, we had adjuvant and neoadjuvant chemotherapy at the time. I think one trial was run by the MRC, might have been David Cunningham, and the other was run by, I think, David Kelson and David Ilson, where we gave a couple of cycles of 5-FU platin before esophagectomy. And one trial was positive and one wasn't. So that was nice to have, but we were continuing to look for something better. And so next thing that came along, I think you mentioned MAGIC trial, right? That was driven by David Cunningham and the MRC and our colleagues in Europe, where they decided to give chemo pre-post to resectable gastric cancer. The MAGIC trial had 20%, I think, were GE junction. So I applied it to junction distal esophagus, as did other people.
And they made their control just surgery alone in that study because some of these other strategies hadn't really panned out.
That's right.
So they're like, you know what? Maybe just doing it before or after is not enough. Let's just do it before and after.
Yeah, more is better in oncology, right?
It's
maybe
an unfortunate trend that we see. Yes.
I know. Well, they did. They might have started those studies concurrently. Well, probably not. But you're right. Why did they decide to add chemo after when they had just studied it before? Well, I suppose it just kind of makes sense that if you start it ahead of time and give it afterwards. But I'm guessing that the intergroup trial with chemo RT adjuvant was going kind of concurrently at that time. So the control arm of MAGIC was, as you say, was surgery. Surgery alone. Yeah. Yeah.
And I was looking back at the classic trial, which didn't accrue in North America or Europe, but in that study, they just did surgery versus surgery followed by adjuvant chemotherapy in Asia. And that seemed to make a big difference, but we hadn't seen that pan out in our population, correct?
Correct. And that, I think, was also a matter of, timing. Yeah. Maybe geography, but also maybe practice patterns. But I think particularly with the classic trial, which gave adjuvant Xeloda oxaliplatin. So we'd updated the platinum generation to third generation for, I think it was 6 months. You have to double check me. It might have been 8 cycles. I think that came up because the practice pattern in China, Japan, Korea was to operate first. And those are almost all gastric cancers, as you know. I don't think there were almost any GE junctions in classic. But that actually worked. I think the hazard ratio was in the mid 0.7s.
Yeah, we'll come to Matterhorn, but when I was looking at it, it seemed like their 3-year DFS rate was a little, oddly close to where we're at in the modern day in North America, which I think, in my opinion, would probably speak to the quality of their surgery that they're doing in Asia.
I agree.
Their D2 gastrectomies might be of...
Well, you're not going to ask me about the difference between a D1 and a D2 and a D3 node dissection.
I mean, I think for our audience, if you don't mind explaining.
No, I'm going to give you some. I won't give you the real phone numbers, but some contacts from my colleagues who do surgery. So they can discuss that. I think the classic was at least D2. I think.
Yeah, I think it was D2,
but not a D3.
Yeah. So, okay, we did MAGIC and then basically switched around the chemotherapy to come to FLOT 4 trial.
We did. Yeah, and there was a trial, I guess in between. I'm trying to link the series in my head. but we were starting with surgery only, right? And then we went to studies that looked at adjuvant chemo-RT, adjuvant chemo, and we had preoperative chemotherapy.
Yeah.
Eventually rolling into the MAGIC trial, which was pre and post chemotherapy, but it was not FLOT, it was not FOLFOX, it was an epirubicin-based triplet.
Vicious.
Which I know, I'm telling
It's
you.
vicious.
I think I called it EOX or something like that.
Yeah.
Anyway, it was epirubicin platinum 5FU, and you
Yeah.
could switch out the OX with the cis or something like
Yeah.
that. And yeah, that was a winner versus surgery alone. But, you know, we don't use anthracyclines anymore for this cancer. We'll just leave it at that.
Yeah.
And so the next trial iteration, I suppose it's not necessarily more is better. In this case, it may just be a difference of chemo is better. And the AIO FLOT trial proceeded. And the nice way you can look at it stepwise is because the MAGIC trial was surgery versus surgery chemo. But then they took the surgery chemo arm, which was the new standard, and they compared a new chemotherapy to the ECF, EOF, EOX, and that was FLOT. And that was the AIO trial, which was also very, very positive.
Yeah. And yeah, it's interesting. And that came out just over 10 years ago.
Sounds about right.
And we didn't really do much different until all of a sudden things rapidly changed in the field.
Well, can we geek out some more about esophageal cancer?
We should.
Well, you start.
I mean,
because you're a bigger geek than I am.
Well, I think a lot of us in North America we certainly did FLOT for gastric, but especially the GEJ, esophagus, I think we definitely still had a leaning for chemoradiation. I'm definitely was in that camp. And so that was in North America really the standard cross-based, chemoradiation.
Yeah. You're right. We had each side of the ocean, this being the Atlantic in this case. We, as in North America, I suppose, Canada, would give preoperative concurrent chemoradiation for both squamous and adenocarcinoma. There were a couple of, actually back when I was training, it's an interesting teaching bit if I have a sec about doing clinical trials and what you'd use in practicing medicine versus what's available on a study. Because my mentor, Arlene Forstier, taught me, many things, but we used the neoadjuvant approach. But we were using it and there wasn't a really definitive trial. We were just using it, which is something we want to do in oncology because we want to give our patients the latest and the greatest. So the intergroups, if I recall, started a study called RTOG. I'm going to forget the number. Sorry about that. But anyway, the randomization was surgery alone, which you could argue was not an appropriate randomization at the time, given the pre-op and the post-op trials, versus neoadjuvant. And I believe it was cis, infusional 5FU, radiotherapy, versus
that's a hard course
surgery.
Yeah.
And the trial did not accrue. It accrued 56 patients. And this was a randomized phase 3, break the bank, pick the trial winner for all time, kind of like what Cross ended up being. And it turned out, if my memory serves me, that it didn't accrue because investigators were not within equipoise of putting patients on the control arm at the time. So the practical use had advanced beyond the trial. Nevertheless, as they say, it was underpowered, but it was still positive for chemo-RT surgery versus surgery alone. And that, among other studies, there were some done in France, in Germany, and then a couple of meta-analyses which suggested that preoperative chemo-RT was better than surgery alone. So that's how I learned. Kind of dyed in the wool, a little stubborn about it. But, I all my rowdy friends were doing it too. So I kept it up until you were mentioning a trial that came out comparing it to perioperative chemotherapy, maybe like ESOPEC, 2 years ago, perhaps at ASCO.
Yeah, we're coming up on 2 years, the ESOPEC study, which, was a pretty clean design, honestly. It's hard to argue. German, right? German study, was it?
I believe. No, ESOPEC was I don't know where it started, but it was
Okay.
more global. Yeah, it was
More
a big
global.
study, hundreds of patients.
Yeah, pretty clean design, perioperative FLOT versus chemoradiation. And granted, they did not give adjuvant nivolumab, which
Correct.
we had started doing
Correct.
in the chemoradiation group. But even despite that, seemed to be pretty convincing evidence.
Yeah, I had to admit that perioperative chemotherapy was a good thing. Of course,
not an easy thing.
No. I wouldn't say, but I would say I had to. It took me a little while to catch up to the crowd, so I tried to, I'm a junior scientist, as they say, tried to figure out the flaws in ESOPEC. So if I may,
I think that's a good thing, right?
Well,
you got to be critically appraise your literature. That's what we're taught to do, but please.
But with just, I use perioperative chemo now, but when we were thinking about it, what could be have been done better, shoulda, coulda, woulda, which you can't because clinical research takes so long that you've already got other stuff. It's just so hard. But we know there were two things: the control arm, and by the way, this ESOPEC was only adenocarcinomas, whereas the cross trial, I think, was about 25% squamous cell cancers. But what we learned, gosh, Eric, I hope I get this right. I'm on video. Is that there was a new standard of care for the cross-treated patients, which was borne out with a friend of mine, Ronan Kelly, where for patients who had a non-path CR to chemoradiotherapy, which I'll just say for all intents and purposes about 30%, but squams are higher, patients would be randomized to a year of adjuvant nivolumab versus observation. That was called Checkmate 577. It's published and it was updated, I think, at ASCO this year. It met EFS, but not OS. But if you look closely, the median survival differences are really, really wide apart. So I'm still a fan of that. But the ESOPEC control arm, I'll call it the ESOPEC cross control arm, did not have adjuvant nivolumab in it. So that could have, I suppose,
swayed the results,
weighted in more of the favor of cross. There was another reason that I thought they were different, but I think that is at the moment sneaking past me. But either way, ESOPEC became the standard of care, which is FLOT times 4 surgery FLOT.
And I guess my simple mind, in community oncology, we have to distill things down into why, why do we do this? Because I have to explain it to a patient, right?
Well, I do the same thing in my practice, and I just usually, we fake it. No, I'm kidding.
But I mean, in my simple mind, why perioperative chemo would make better sense than chemoradiation would be higher dose chemo up front, eliminating micrometastatic disease.
Concur.
Before surgery, because once you go to surgery, it's kind of a long wait.
It is.
And
it is.
Things can grow up and seeds can become plants.
Agree. Yeah.
Yeah.
And I think
that's my simplistic understanding.
That's my understanding too.
Okay.
So again, we see eye to eye, even though you're taller when we stand up. But the idea of systemic control versus local control, I think, is another paradigm where you can place the understanding of this.
Yeah.
So systemic therapy is systemic micrometastases, and local therapy is surgery or radiation.
Yeah. Basically.
And which of those compartments are responsible for the lower survival? And I think what we learned from perioperative surgery chemo is several things. One is that systemic doses of systemic chemo, because the doses in cross are low weekly doses of Taxol platinum, are important. They still have a path CR rate of around 10 to 15%, I think, in ESOPEC. But then if there are any stragglers behind after surgery, you have this adjuvant. I call it an insurance policy when I talk to my patients. So you debulk systemically, you get rid of the systemic micromets, you take out the source of the mets, and then you give something afterwards to finish the job.
Yeah. And then, this was very quickly followed by a couple studies that read out, Keynote 585 and Matterhorn.
That's right.
A little bit of difference in design between those two studies. One was negative, one was positive. The positive one, of course, changed practice.
Yes.
Yeah.
The advent of DFLOT.
DFLOT.
As Dr. Klempner said in his very excellent
got a lot of applause
section.
for it.
Oh, my goodness.
People love a good acronym.
Yeah, he got a lot of applause when he said, I'm going to name it DFLOT.
Which he deserves.
I guess. It's kind of like maybe if you're an astronomist and you want to name astronomer and you want to name a star after your dog or something. But whatever finds interesting. But I will say in all seriousness that, okay, I'm going to geek out a little more, but you guys know me, so it's no surprise. And since I've been doing this job, when I trained with Arlene first year in the 2000 early aughts, we had 2 in a row plenary sessions for esophageal gastric cancer. 2 in a row. Okay, we can end here. Drop the mic.
2 in a row.
No, so ESOPEC showed that perioperative chemo is superior to preoperative chemo-RT, and that shifted practice hugely because so many folks were using cross, including ECOG, right? That was our backbone regimen for studies like for EA2174 that Jennifer Eads is running. But also the second one was Matterhorn, which is, oh my goodness, immunotherapy works in the upfront setting. What a gift.
I know.
But it is, it's a blessing to have that data. And I like the DFLOT, the DFLOT name quite a bit. There are some caveats or points to be mentioned about Matterhorn if you wish. We can also talk about what we might consider down the road to make things even better.
Yeah. I think we haven't dove into a ton of cases at this point, but I feel like we should make this a little more applicable. And we'll kind of centered around this now standard of care DFLOT, maybe sprinkling in some data throughout a couple of cases. So let's think about a patient. You can see a lot of variation in how patients will tolerate treatments, even just across the United States, depending on where they live geographically. But DFLOT, even though the immunotherapy per their data did not worsen toxicity at all, the FLOT is still FLOT. It's kind of hard, right?
It is FLOT.
And so we have to really select our patients for this regimen.
Agree.
So let's say you've got a 68-year-old female, otherwise healthy, maybe BMI in the high 20s, had some chronic GERD, leading to her GEJ adenocarcinoma. This is looking resectable, right? We've gotten our CT scans, we've done our EUS,
got
her PET. It looks like there's a lymph node nearby that's lighting up on the PET scan and a little enlarged in EUS, but we're not seeing anything distantly. Are your surgeons wanting to do diagnostic laparoscopies on everyone if you've got a negative PET?
Yeah, that's a whole talk in and of itself.
Yeah.
You talked about, you don't mean it that way, my surgeons, but the surgeons I work with who are spectacular, of course.
Wait, they don't work for you?
Yeah, no, never works that way. Know the order, Eric. You've been doing this long enough.
If anything, we work for them. Let's
Who'd
be
you
real.
learn from anyway? The reason generally speaking, if it's GE junction and not signet ring cell, we tend to not lap stage patients. Anything that's true gastric, which is farther down into the abdominal cavity below the distal thorax, we do lap stage. I believe my colleague Deepa McGee here, I think she leads our intraperitoneal malignancies group as part of our one of my surgical colleagues, quotes me 15% occult, something like that. So I base it on anatomy, whether or not to lap stage, and I guess histology as well.
Yeah, I mean, I've always read that a PET can upstage in about 10% of cases. If you've got the negative PET, what does the laparoscopy add? I guess
I think it does. It adds maybe about that much more.
Yeah, that much more.
Yeah, the false negative rate for Mets with CT was about 10% back in some Dutch investigators. Flamen, I think, did that study. But it's clear that, at least in my practice, two things as caveats. I really don't see a whole lot of what I call real gastric cancer.
Yeah.
Because I live here.
Yeah.
Most of ours, quote unquote, is GE junction and esophagus related to Barrett's exposure. But gastric cancer, if it's not in the junction, I'm going to send them for lab staging.
Yeah.
Now, some would argue that why don't you just give them you're going to give them chemo anyway, if it's lab positive or not, because they're either going to go to surgery or not. So one other approach is just to treat them and lap stage them at resection. But I prefer not to do that now because we have trials where we can treat peritoneal-only disease with intraperitoneal chemotherapy.
You're doing high-PEC.
So we could plan for that,
Yeah.
STOPGAP is the trial through cooperative groups.
Nice. Yeah. So biomarkers, I mean, it's not as big of a topic in the current standard of care space for upper GI cancers. As we all know, HER2, Claudin, PD-1, CPS scores are all important when it comes to the metastatic setting. In the upper GI space for resectable disease, we're not currently differentiating, but it's a good point. These things could be coming down the road. Is your path lab reflexively sending these things? Ours is not. Ours is reflexively sending PD-1 CPS scores on everyone.
Yeah.
I guess just cause.
Well, we recently have enacted I guess you call it a reflex in-house panel, which a number of them we used to do with our vendor is Tempus, but we get microsatellite, we get HER2, Claudin, and I'll call it CPS score. For everyone, although usually those are most useful for patients in the recurrent metastatic setting. But the ability to have them fast is helpful in a patient who's being treated with curative intent, because the patient feels that every second is days to wait to start. So if you can have those studies up front, it can allow you to stratify. At the moment, we only have immunotherapy from Matterhorn, DFLOT as a marker, although you could argue that you can give Durvalumab to patients who are CPS 0 based on the current practices. But that's a discussion for another time. But for other markers, there are trials. For example, you mentioned the markers, so they're great. So what can you combine and sequence together? Well, somebody did this. I think we have a trial that came out called Illustro recently, which was looking at Claudin, immunotherapy, chemotherapy, if I recall. It's phase 2. It's an Astellas trial, and it was incredibly promising. So they've rolled that into a study called Lucerna. So we're starting to move these markers.
I think we've looked at opening that study.
Oh, good. I'm glad.
Zolbetuximab, So
I can refer people to you, and you can refer them to me.
Yeah.
Excellent.
If they're willing to do so.
Well, spring comes sooner here. So just saying.
All right. So we've got our patient. We'll say they have T3N1 disease based on preoperative staging. No intraperitoneal Mets. We were super thorough. Got a diagnostic laparoscopy. DFLOT. All right. We give her cycle 1. It doesn't go great. She just has bad cytopenias, bad nausea, vomiting. And she's like, I don't care. I want something less intense. What's the first thing you do? This is for our, we're getting into practical things now.
I know. That's what's so hard, isn't it?
Because it's 4 cycles ideally, right?
Correct.
Every 3 weeks, kind of a rough 3 months go there. But
it's the Durva's given monthly.
We all know
the FLOT's given every 2 weeks.
Not all of our patients are the fit population that was able to get on Matterhorn, right?
Concur.
On ESOPEC. So how do we adapt this to our people throughout the country?
Big sigh. Well, I have an answer, but of course I want to qualify it before I give it to you. Maybe I just like to make you listen to me talk, but It's the clinical dilemma of trying to predict what's going to happen based on variables you can't know. So you can make a list, or we all can, of performance status, organ function,
Right.
Performance status plus a multivariate equation of all these other things, and we can plug it in, and it says this patient has an 80% chance of tolerating DFLOT. But even that would only give you an 80%. So you have, I think you have you have three options if the patient wasn't able to handle the first FLOT. You could delay and reduce doses, but
Right.
those are three drugs. You have to pick which one of them or those.
Who do we pick first?
Exactly. who gets the first tap out? Or you could drop a drug, or you could stop. I wouldn't stop and go straight to surgery. You can obviously adjust things, but it's balancing curative intent versus two things: quality of life, but ability to get dose intensity. You have an out, though, and the out is not to default to chemo-RT. The out, in my practice, and I'll actually put it out there online, is you can change to FOLFOX-based preoperative therapy, and you can get immunotherapy with that because you've kind of already got it from the DFLOT approval.
I would say that's what most the physicians in our group are doing too. If it's someone that you're more worried about, or who's just not tolerating things, the docetaxel is the first thing to go.
Agreed.
Probably because we're just simplistic, right? And we just love to give FOLFOX.
Well,
GI medical oncologist. It's just
isn't that the answer for GI? Unless it's for tubular GI, the answer is always FOLFOX, right? So
yeah,
helps me out a lot.
Yeah, and I would say then you're getting into fairly rare territory of patients who can't then finish out the FOLFOX durvalumab.
Yeah.
There are still a few unfit patients. I've had one in my clinic that comes to mind in particular who was just really not a chemo candidate, period.
Understood.
But she wanted curative intent treatment. And we did definitive chemoradiation, no surgery.
Agreed.
And she's sitting here a year out with an esophageal adenocarcinoma, no recurrence.
Well, it happens. I mean, first of all, I'm not sure everybody will agree with me in the current setting, especially in immunologic unstable tumors, but you have to have surgery. I'll just put it out there to cure esophageal gastric cancer. So that's the one thing I would not leave out if I didn't have to. But historically, I used to split the benefit of chemo-RT between adenos and squames. Because in squamous cells, which we're not talking about, but there are studies, one in particular whose name I can't remember, but it was a definitive chemo-RT versus RT alone for squames. And the cure rate was 25% in the 5-year follow-up. So you can definitely cure. And that's one standard of care for squames. It's RT.
For sure.
But I would always teach people that you can't cure, never say never, right? You can't cure adenocarcinoma without surgery, but you can. You just told me, but also there's a study called RTOG 1010, I think, that came out of the University of Maryland. I don't know how they got away with this, honestly, but the control arm, or it was basically looking at HER2 positive disease, chemo-RT plus or minus Herceptin. But the control arm was chemo-RT, and it had some adenos. And there were some cures there, 10% maybe. So it does exist. Yeah,
I know it's a good point to make, because having your stomach removed is not a great fun operation, and more importantly, functionally, your life is forever altered after that. Right?
Certainly is. Yeah.
So any strategy we can eventually maybe think of to do that would be nice.
Yeah.
So okay, we get them to surgery. Let's talk about some scenarios here. We didn't really address her upfront PD-L1 CPS score.
Yes.
But in Matterhorn, that didn't really seem to matter, right? The benefit was seen regardless of CPS score, which is really interesting when you think about all of the metastatic studies that suggested differently.
Somewhat controversially, though, 10% of the patients, if I recall, had a CPS of 0. If you look at the forest plot, I think it is, there's no subset benefit of survival, but that is, as they say, a retrospective subsort cohort analysis.
And I think it still trended towards benefit, and it was just a very wide confidence interval. So,
and I don't know. I should have read this, but I'm sure it's the FDA gave it as it was in the paper, which is agnostic of CPS score.
Yeah. It's just interesting.
I agree.
But yeah, so she goes to surgery. What would you think to yourself if she had a pathologic complete response, meaning no residual tumor cells versus some residual tumor cells? I mean, that's still certainly investigative in upper GI space. What would you think about that? Would that change your outlook for her? Change your postoperative approach?
Yeah, so I appreciate the question. 20% of the patients in the D arm of DFLOT had a path CR.
Yeah.
And about 50% of the patients got the entire post-op dose intensity. And adding the durvalumab did not change delivery of the chemo. I think if I'm reading your mind, which I'm probably scary if I could, is that should I not give them as much adjuvant therapy because they had a path CR?
I think it's a big question in the field. Like, are we overtreating some patients? It feels a little scary, right, when you think about the historical disease-free survival curves. Even in Matterhorn, the 2-year DFS was 67, 69%, somewhere in there.
Good, huh?
So it's pretty good, but there's still a third of patients there who recurred or passed away.
I agree.
Within 2 years. So, to think about de-escalation feels scary.
I will agree with you.
Yeah. But I know companies and academics are thinking about ways we could de-escalate things based on various factors.
I do appreciate the word de-escalate, or in this case, potentially avoid more chemoimmuno or even avoid surgery.
Yeah.
Because if you talk to folks that are in CDH positive familial gastric cancer who are facing a prophylactic gastrectomy, that's a huge thing, right? I can't even say how huge it is because it's not me, but in the future, if we could not have to have surgery as part of the multimodality care. But your case is I followed the books. So I will finish off there. Adjuvant.
Yeah. I mean, that's the correct answer, right? These are all theoretical investigational things. Our current standard is still to wrap it up and get through it. Which in the best of circumstances on a global phase 3 clinical trial, only about 50% of people get the whole way through.
Yeah, that's right.
And maybe 1 in 4 people don't get any postoperative.
And I don't remember the data of how many who didn't get all the cytotoxic continued the 10 extra months of monthly Durva as maintenance. I don't know that.
And that's another remaining question. Do we really need to give a full year of Durva?
Exactly.
We do
or could you, I'm just getting myself in trouble, but could you, if they had a path CR, could you just give them adjuvant Durva and not FLOT?
Yeah.
All kinds of things.
It's a great question.
Like that. Yeah. There is a study, I think it's going on in Germany, of TNT DFLOT. So they're looking at all 8.
Yeah, I've seen that. Yeah.
I think the preliminary either data or justification is you could get a higher path CR rate because you get the entire dose intensity in theoretically before they have surgery. Because postoperatively, historically, it's always been difficult to get all the chemo in. So it makes a lot of sense.
I mean, I think that leads us to a good point of the future now.
Yeah, of course.
And where we're going in this field. What do you foresee? There's so many different permutations, right, of how we could then try to improve upon the fact that a third of patients are still not having an optimal outcome at 2 years. It'd be nice if we were doing as well as breast cancer. And even that, our breast oncologists would say they could do better, which I agree.
Because they do. Well, I hear you. So historically, just remember though, in 20 years, my numbers will not be absolutely right, but you'll get the idea, is the cure rate was 20% or something with surgery alone.
Man.
And now in Matterhorn, what was it, 60% or something like that? So
67.
So we moved the needle
69.
a long way in 20 years. I think in the future, and don't test my knowledge of permutations because it's been a long time since I took statistics in graduate school, so at least I don't know what the word means. Combinations and sequences, I believe. That's what we need to do. So historically, we move things from the recurrent metastatic setting up into the curative setting. So trials like Illustro and Lucerna is a drink. Lucerna are looking at adding Claudin to IO and chemotherapy. There's Herceptin, but TDXD, that's moving up front, et cetera, et cetera. So we're trying to move the needle where we get rid of even more of that systemic micrometastatic disease with pre, and then reduce any leftovers with post by sort of dose intensifying the perioperative. The surgical approaches are so good now and laparoscopic, and it's incredible.
And, I've heard murmurings too of people thinking about a TNT approach, like you've already alluded to, maybe all 8 cycles of chemo prior to surgery.
Exactly.
I know people are pushing that in their tumor boards.
Yeah. We do that in pancreas cancer all the time with FOLFIRINOX. So I'll put myself on a limb, and I think it'll be as good, if not better.
Yeah.
Yeah.
And could you foresee a future where a trial is run such that you give DFLOT followed by chemoradiation and then surgery? In a patient who's medically unfit? I guess that wouldn't really make sense, because if they're medically unfit for surgery, they're also probably not the most fit for...
Yeah. Well, I know the
FLOT.
The concurrent chemo versus chemo, that kind of thing. The trial that came out of Australia was negative. And I think that might have been how Neo-Aegis worked, if I recall.
Okay.
So I would look at it maybe a little bit differently. I'm going to say that we have our new paradigm, which is DFLOT.
Yeah.
So cytotoxics plus cassette A, B, C, D of targeted or directed therapy.
Yeah.
So that's one way we're going to move. But the second way we're going to move is, unless we get more targets, that's not for us to talk about here, I don't think, is organ preservation. And how can you do that? Well, there is a study who I always get the name wrong. Neopigna, is it? I think, something like that. Anyway, they were patients who had MSI high.
Yeah.
And they got IO only. And some patients said, hey, I don't want to go to surgery. That's fine. And they didn't recur.
Yeah.
So that is pretty groundbreaking. That's MSI high with immunotherapy, but I know you and I have talked a lot about in our past ctDNA as a predictive marker for recurrence or not, and whether or not to give adjuvant something or not. And I think biomarkers such as that, which are, I'm not going to say better than imaging, but adjunctive to imaging, may help us better choose which patients may not need to either have surgery at all or to have adjuvant therapy postoperatively.
Yeah. So a lot to think about. At the end of the day, right now we're doing DFLOT for our patients who maybe can't get full triplet chemotherapy, dropping docetaxel.
Agree.
So DFOX.
DFX.
DFOX.
You can make, hey, you're here. You can make you can name something.
I like DFOX.
You should go for it.
We're going to do DFOX.
Well, you planted your flag like MTV, and now everybody's
sounds
like
have to some new mammalian species. That
doesn't it? Yeah. Yeah.
But we'll see what the future holds.
I am ever hopeful, more so all the time because of what we just talked about, the history of things moving forward, but also, just knowing that, over 20 years or so, because of all of the science and the investigators and families and the patients who bravely gone on clinical trials, the cure rates are up and there's more hope to follow.
Yeah. And I recently wrote an article about kind of my rudimentary predictions of where we're going to be in 30 years. And I predicted that we're going to be not giving chemo anymore. a strong prediction.
I think that's...
but if you think about where we were 30 years ago...
Well, when I was training, I had just gotten a cell phone. No, I'm kidding. We didn't have AI, so who knows, right?
Right,
Yeah.
right. So, and then maybe when treatments get good enough, like a Neopigna MSI high approach, maybe we can avoid gastrectomy altogether. We'll see.
That would be fantastic.
That's a hopeful future. Let's hope for it.
Hope it is. And thank you so much. I've enjoyed it very much.
Always a pleasure.
Always great to see you, my friend. So, thank you.
Thank you.
Generally speaking, if it's GE junction and not signet ring cell, we tend to not.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles,
John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.